Welcome back to the next session, which is more about becoming an independent operator and about challenging cases, prevention and management of complications, and tips and tricks. So I think we're going to go live to CVC. Hello, Horst.
So welcome back. We have the same team as before: Laura, Kolja, Yasemin, Julia somewhere, Nina, and Jennifer is ready for the case history. Jennifer, please.
Our next patient is an 85-year-old female with paroxysmal atrial fibrillation since August 2017, currently treated with apixaban. Her medical history includes hypertension treated with a renal denervation in May of 2012, a coronary artery disease with multiple PCIs and 2 CABGs, furthermore a peripheral artery disease and sleep apnea. Her risk scores include a CHA2DS2-VASc score of 5, a CHAD score of 2, and a Hasbulat score of 3. Her ECG currently shows a sinus rhythm, a complete right bundle branch block, and an AV block grade 1. TTE showed concentric left ventricular hypertrophy, a normal left ventricular ejection fraction, and a mitral and tricuspid regurgitation.
And we have Laura with the imaging, please. TE.
Well, TE at 55 and 145 degrees. We see the left atrial appendage. It's bent slightly towards anterior, and it has small additional pockets, but one main lobe going slightly to anterior, like windpipe or slight chicken wing morphology.
Did you already measure the landing zone?
Well, I haven't yet, but I will do that. I will do that on 3D.
While she is doing these measurements, any opinions regarding which device can be used here? All of them, or would anybody of you say, well, this has to be done with one or the other one?
I think, Horst, looking at it, I think maybe any of the devices would be okay with this.
Okay.
I mean, it looks like there's enough depth for for a Watchman, and similarly for Amulet, Lambrey, or Wavecrest. And clearly, Lariat would work as well.
Okay. So should we go for bicable first or measurements first? What do you think?
If you, up to you.
Okay, then go for a bicable view first. I already have the transeptal sheath in place.
I have here so really long septum secundum.
Yeah, maybe if we could see the echo as well.
Oh yeah, we need echo and fluoro on screen, please. And my hands, if possible. Okay. So I'm pointing with the needle towards 5 o'clock. I'm slowly coming down. I see on fluoro that although the arrow is now at 4 o'clock, the curve is pointing posteriorly, so I go a little bit more anteriorly. That means I'm now at 3 o'clock or 3:30. I can advance the needle a little bit more, and then I continue to pull down. Let me do this here. Okay. It really has a trend towards posterior rotation, so now I'm at 4 o'clock, which is unusual for the fluoro imaging. You see the tenting on the septum secundum. You see that we are in the mid part of the septum in the short axis view.
But actually it is secundum. Well,
now it's secundum, yeah, I just pulled down.
You just,
and we
it's
are,
jumped.
well, in the middle of the septum, right?
Well, yeah. At the middle of the fossa, but
the middle of the
is
fossa, yeah.
located a bit more inferior in this
case. I go a little bit more posterior, like this. How is the situation now? Is that good?
Good.
Okay. So I puncture now.
Yeah.
Can we have pressure on the monitor as well?
You are tenting.
Tenting, right. So it does not go through. So what I do then is
You also seem to be moving more mid.
yeah, correct. I go a little more
Yeah, you
posterior.
are through now.
Oh, no, it's through.
Yeah.
Okay. Should I take it anyway, Samir? What do you think?
I think for this one, the appendage is the famous last words more on the straightforward side. So I think this mid should be okay, but I'll point back to other people in the audience. Does anybody think that we should go back to the inferior posterior, the classic one, or should we take this? Peter, what would you say?
Sorry, I stepped in too late and I didn't get the imagination. No, I see it.
Oh, Peter is never satisfied with the puncture side, so big mistake to ask
That's
him.
our whole discussion all the time. I think it should work.
Martin, you agree?
I think it's fine.
Okay.
So if this is an important point, if the appendage you think is more on the straightforward side, and you happen to be mid, but as long as you're inferior, it's okay. You would agree with that?
Perfectly, yeah. I think we also have always to consider if you start to fiddle around too much with your transeptal point, you end up with more complications, which we try to avoid.
So I see the pressure in the left atrium is, again, pretty low. It's about 7. So we should give some additional fluids, please. Mehr Infusionen. I had advanced the sheath over the dilator. Now aspirating, making sure there's no air. Show my hands. No air in the valve of the sheath. And we give 10,000 units of heparin. And can we have the pigtail?
Maurice, how do you give more fluid in your lab? Do you give, what do you tell the anesthesia, or how do you set this up?
Yeah, they insist on having an IJ line, even though I tell them they don't need to. And I think that's how they get paid. So we basically ask them to give the fluid through the IJ.
And how effective is it?
It does, actually. I was skeptical all along and say, 50, 500 or 250, it's not going to do much acutely, but it does.
For those people that do not have IJ lines, I think where I'm at, I've been able to give fluid into the left atrium directly after transeptal puncture, just 1 or 2 50 cc syringes. For people with low EF, you have to worry about pulmonary edema and fluid overload, but for most patients, they're able to tolerate it. So
that's a good idea, and there is another access site because we put 16 Frenches in everybody, so there is plenty of room between the 14 and the 16. But anesthesia doesn't get paid.
Okay, so now the pigtail is already in the appendage. We have a flow rate of 9 per second and 9 cc volume. Okay, inject. Good. So the question is now where to measure.
It depends what device, right?
Okay, so let's go for a watchman. So where to measure with the watchman?
I think this comment by Maurice is quite interesting when he asked, because that means we're not talking about the osteum, but a landing zone for each device, which is different. We always say we're measuring the osteum, but it's different for each device.
So this would be X1. We can also measure something like this here.
So now that you're measuring, did we decide what this is called, this appendage? Is it like there's a chicken wing, there's a good turn there on the angio, but the good news is that it is with depth. So there are different, when people say, oh, it's a chicken wing, doesn't exclude it from anything. You have to realize that it is with or without depth.
Okay, so which measurement is the correct one?
How many people think the furthest to the left measurement is the correct one? Raise your hands.
So we have 17, 21, and 21 actually.
How many people think the middle measurement is the correct one? Raise your hand. You have about 20 people raise their hands. How many people think the furthest to the right one is the correct one? Raise your hands. Kevin raised his hand, so about 5 other people followed him. So, and then how many people still don't know?
I still don't know because I need to look at the echo and see where the circumflex is and then try to correlate that dimension in 3D with this.
So Laura has done the measurements now,
Yeah.
I think.
I think I have measured pretty at the same position you have done it. As you see here, so here is circumflex at the same level. The biggest diameter is 21. Yeah, I measured it here. The biggest diameter is 21, but I took the another measurements, perhaps a bit lower, much more lower. It's 15, and something in between. It's 18.
Where is the 135 view?
Here.
How much? What's the measurement there?
Well, I can measure.
See, I think that 135 view measurement is an imperative when you're dealing with watchmen.
Well, would you guide me, please, Morris?
No, you're doing good. You're doing great.
It's okay here? From
Yeah,
here
look
to
great.
that? Okay, 11.
11 there.
11.
So now,
It is perhaps this diameter.
yeah. So because the difference between the other views and the 135. But is this really the 135 opened up maximally? Maybe we could do it live.
Live 3D or live 145?
Live 135, if you
Okay.
would, please,
Yeah.
to get the most expanded 135. And you've been giving fluid all along now.
Yeah. Fluid is running now.
Maybe I've been doing this wrong for a long time, but I just make it a simple approach to just go for the largest diameter I can measure. So this would be the 21,
Well, that is my
without-
idea too. Yeah.
without going too much intellectual here.
Actually,
I
if you
always
had
thought
a
you are
nice
very
quick-
intellectual, so I'm surprised.
Yeah,
There was
It's
a
not the
nice
intellectual
3D
part.
reconstruction and
it's
the
not
nice
the intellectual part or not. It is just trying to find a device that you're not too compressed and yet you're under compressed. So you need to know all of them, and in my view, it is the preponderance of the two. Right there. Yeah, that's it. Right there. You see the os a little bit more fine, and then you'll see where the circumflex is. Just a couple of toggles right there to right there. Yeah,
14.
Still pretty small. So who shrunk my appendage here? Huh?
yeah.
So then we have now 14 on the 135 degree, and we have 21 and 17, depending on where you measure, on angiography.
And if you think of 21 and 17, so you cannot do the oversizing you like, the 24, 24, so you need 24 depth. So I'm confused by the angio. That's why I never do the angiogram measurement.
Okay, just close your eyes, just focus on the echo. Which device would you pick then, just looking at the echo?
So the depth, the maximum depth, Laura, is what?
20
20.
and 135.
So no doubt, I would not go more than maybe 21 or 24 if I want to squeeze it and accept a shoulder.
What's your first device you choose, 21 or 24?
One more time, repeat all numbers, please. What are the numbers you had? Minus 130, yeah.
21. Wait a moment. Here. So it was a bit deep.
Laura,
It
the
was,
maximum depth was 27, wasn't it? The maximum depth.
Yeah, it is, but it was in 65 degrees something, not in 135. But
Not in the standard views.
yeah.
And lastly, while you're doing that, I kind of rely a little bit on the 3D to be the judge between all these numbers.
Okay, if I take from here to here, it is the depth 21.
21, yeah. So I would probably start with a 21, knowing that I may need 24.
So with 21 being the measurement I go for 24, and we don't measure depth with echo, but I just see how much I can push in the
This
watchman
is because
sheet.
you are doing for 30% oversizing,
Yeah.
right?
Yeah,
and
we don't.
the depths can be easily measured with the sheath. I never trust actually the echo depths. If you have the pigtail in and follow the sheath, I would think we have enough depths.
I
you're
think
doing it-
I agree with you because I think that we do not see the very tip of this appendage here in echo. Perhaps it could be would be possible to elaborate it from 3D, but what I have mentioned is not the very tip.
It's not fair to do it with the 135. The depth is in the lower and the width is in the higher projections. So usually it's said that it is in the 45 to the 90 where you have the most depth if you are in line. So if you go back to the 45 to 90, you will see that there is depth, whether it's 21 or 24, we're talking about not too much. But Martin Bergman, I think you are going against IFU.
But for personal feeling, I would also go for a 24 because you have a very wide opening up there. And if you can go back up to the border of the RFIs, it might be suitable to have a larger device to fill up this region.
So, Peter, what size larger device?
A 24.
And
Let's look
larger
at the let's look at the sizing chart. Can we bring this into the picture, please, Thomas? So you have to move away. Okay.
Well, I
So
think-
if the measurement is 17 to 20, then 21 millimeter device. Most of you, as I understood, will go for the 24, which means not following the IFU but oversizing. And Maurice would actually use a 21, which means also not following the IFU, because according to the IFU, you cannot use it in an appendage which is smaller than 17.
But this is, she said 20. What are you talking about?
21.
Well, in the 135 degree, it was 14, right?
Yeah, but the preponderance, all the other measurements were in the 20.
I'm just kidding, as you know, because you said for you the important
I
measurement.
always respect the IFU.
Of course, you are an American, and you said your important measurement is 133 degree, right?
Yeah, 135, correct.
Yeah.
Well, and then this biplane imaging 50 and 140 perhaps, and 50 degrees we have the measurements is 15. Here in this view is 14, and the depth here is 27.
Yeah, so that's why I'm surprised at Peter's sixth comment, whereby he says it doesn't. I'll use the larger one because this would be, if you believe those numbers and they are good pictures. Would be significant oversizing.
But take a look at this picture, right? This is biplane. You're going straight down, up and down. The depth is dependent on where you put the landing zone. The landing zone on the left picture is at an angle. On the right picture, it's at a straight line. Shouldn't they be much more similar to each other in the straight line across to be able to get the landing zone correctly in both?
Well, the correct landing zone, if you want to get it correct in both, that it is 3D. That is this picture, yeah? It was that.
Exactly. And what do you get on 3D in terms of os diameter, minor and major?
I wouldn't call it os. The os I didn't mention. Here is the CX, yeah? Then it was 21 by 13.
So that 15 is the width and 21 is the depth.
13, not 15?
13, okay.
Yeah, 13, yeah.
Yeah. So that's why I'm surprised at the for safety I would use 21, knowing that maybe 24 would be needed if there is para device leak. So I would go with a 21 with a backup 24, but obviously other people feel different.
So, but we all agree this is a straightforward and very simple appendage, right?
That's what I was told at the beginning.
Yeah.
Yeah, I'm surprised, but that's okay.
With the longest discussion.
Yeah.
But you know what? Many times it's this problem.
Yeah.
I think it's
Yeah.
not unusual, or this is really real life, and
Exactly,
it's
yeah.
important to go through that exercise.
Exactly, yeah. I'm rotating against, just in one direction.
So what did you choose, Horst? 27?
I'm still following your discussion and wondering whether anybody has changed. I need
Just don't
a
use
bigger
the 30.
sheath here. I need a bigger sheath. Give me a, what is X?
So Martin,
14 sheath, 14. This is 14. Yeah, this is 14 outer diameter. So a 14 or 16 French sheath would be fine. I cannot go through the skin here. Or through the
14 with this one is kind of tight.
yeah, so
I would go with
16 is better. 16 is better. Yeah.
Martin, you tend to oversize up to 30%. If you did measure a maximum diameter at the ostium of 21 millimeters and you have a 27 millimeter depth, would you even think about a 27 millimeter device?
Oh my. Jeez. It's going to go out the wall there.
But it's a very dynamic-looking appendage, isn't it? I mean, it looks like it would be very compliant for whether 21 or 24 device.
But not 30. Not 30. Stefan is kind of going towards 30.
Could you also make maybe a comment on the sheet selection? So I was wondering if this wouldn't be maybe an appendage suitable for a single curve sheet.
Oh, that's a good question. Yeah. We never use the single curve sheath, so I don't know. Let me go for. I have some problems here to introduce the sheath into the groin, so let me see what's happening here.
Maybe the dilator by itself first.
Really tough. Okay, now I'm in.
There you go.
Yeah.
It is getting caught up on the hip replacement. That's what Kevin
Yeah,
said.
exactly. Yeah. Yeah. So avoid hip replacement in AFib patients. She also had some pain when I introduced the needle into the transeptal sheath. So it has also to do with some straightening of the vessels here. Okay, so sizing is again, the majority is for 24, right?
Yeah.
Nobody changed his mind. So Martin, oversizing, is there any limit? I mean, how much can you oversize, and what happens if you oversize too much?
Indeed, we have looked at that in the evolution registry, and across Europe, this message of oversizing by around 20% apparently is used by most centers. What I fear is actually if you end up releasing these devices too distally. So whenever I go back into the few pericardial effusion cases, I find that if we really have these devices in the distal lobe, they don't open up, then it's a high risk of pericardial effusion. So above 50% is where I get a little nervous. Horst, we have this discussion every time just for teaching purposes. The exchange to the Watchman sheath over the wire in the LAA
is much more safe, right? That's what you always tell me.
It's fine, yeah.
It's not what is written in the IFU, to go with Maurice's words, while we would say that the international IFU of the Watchman has been changed this year, but this is not for the sizing, but for the post-implant drug regimen. I think you will probably mention that later.
But again, what is important, if you do it with my technique, is really to use the wire exactly as you would use the pigtail. So if you use a wrong wire, then I absolutely agree, it may be very dangerous. But this wire really behaves like a pigtail. That's why I feel extremely confident in this technique. It's not that because I have done so many, I think it's really the configuration of the wire which makes the difference.
But in all fairness, the so-called standard technique has also its limitations, because both of them, with a 14 French being 6 French pigtail, or the swire, has a lot of room for the device to create a nick going out. It's not like a dilator fits to that. So there's, it's a shade of gray.
I was always trying to ask Vivek, actually, because it's sort of a history thing. I always thought that big difference between the early and the late PROTECT AF data with the lower pericardial effusion was due to go for the pigtail technique and the inferior vena cava, wasn't it?
Yes. I don't think Vivek is here, but I'm the one who recommended it back then, the pigtail, but I'm still saying it did change, but I don't think it's only because of the use of the pigtail. We changed the anticoagulation regimen. We changed so many things
And
But
global
definitely-
warming also plays a role here.
But definitely, it was it's very hypothetical.
You're just about to introduce this device. One of the things that we discussed, at least at a couple of LAA meetings a while ago, was the parallax that's in these small circles that are on the device. And I think on one of them is, if the sheath is laid out in a certain direction, and if you wanted to really see how this would sit, by just removing some of the parallax, you'd be able to say, okay, this is how the device is going to come out. Does anyone else look at these circles and try to see whether that could contribute to seeing how the device is going to show up in the Ario Call view?
Aspirieren wir ein bisschen.
Crickets, Kevin, crickets.
Yeah, I think you're on your own there.
When you have a depth issue, it's nice to do an angiogram with those markers right now, a gentle angiogram to see if you're going to be too far or too long. So that's the reason why they've been there.
So let's focus here. I have some problems to aspirate. So what I did is I rotated the sheath a little bit and pulled it back a little bit, but still it's not possible yet. So I have to pull a little bit more and rotate.
Yeah, it looks very deep on TE, doesn't it?
Yeah.
Can you rotate a bit towards anterior?
Okay, here it comes. Now we have some backflow.
Yeah.
You moved quite posterior, as Laura mentioned.
Yeah.
Looks good.
And you
It's going
put
in
it
the right direction.
Okay. Okay, but now
And
we have good
before,
backflow.
if
You
I
can
have
flash
so
now.
much doubt before opening a device with the sheath in place in the 135, I do a repeat measurement.
Should I
Okay,
repeat
the device
measurement?
is already in the sheath.
Yeah, he
We
opened.
are going
he
for
opened.
the 24.
Yeah.
So when you do injections during this phase, it's important to connect the injector to the delivery catheter, not to the sheath. So can you go to 3, flow of 3? A little puff. A little puff, more. I'm hitting the wall, so I will rotate it a bit clockwise, which will hopefully bring the sheath more down. Little puff.
We're too far left.
I'm too far out, huh?
Yeah.
Yeah. So I'm rotating clockwise. I go back with the device so that the sheath becomes more flexible. You see that?
Well, now you see
Little
that
puff again.
actually
Again.
the axis
More,
goes
more,
here.
More. Okay. So now I had to pull it back because I could not aspirate.
Yeah, because you are standing here. Look at this.
Can you take a new picture here?
We can, yes, but let me still. Okay, now it's free. Okay.
And you are
Can we
pointing
have an
to
injection?
the
No, go
wall.
to low speed injection. So 3.9 is fine, I think.
You are
I think the
Inject.
sheath position is fine here.
Yeah, I changed it. I was hitting the wall, as you saw, and then I had to.
And by the way, you see where the markers are? You are like at the first marker, which is this is usually the 21 marker.
Yeah. And the 24 would end up between the first and the second marker.
Exactly.
Right? So I rotated the sheath a
What
little
if you
bit clockwise.
What if you clockwise? Okay, clockwise. Turn
I
it a
did
little bit,
that. I turned clockwise, and in addition to that, I had to pull back the device because the device was straightening up the sheath. So now when I pulled back the device, the sheath was more flexible, coming down, and then rotation to the right side. When I look at this, I think I can very carefully advance maybe 2-3 millimeters more. So I will do this now.
and more rotating anteriorly.
And at the end, I will rotate a little bit anteriorly. So now I will rotate anteriorly, which means counterclockwise. So you saw that the sheath was coming up a little bit.
I think it's enough because when you advance the device, it's going to straighten even more. I think
That's
and
correct,
counterclockwise is enough. Otherwise, you'll be again against the wall.
Yeah. So now I'm advancing the device.
See how much straightening it happened.
Yeah. So at this point, I will keep the delivery catheter in place and pull back the sheath. I don't want to go more in as I'm now. So I do this until I feel the click between the delivery catheter and the sheath. So now delivery catheter, sheath and delivery catheter are working as one unit. I'm opening up the THUI on this end here. Keep that in place, looking at fluoro, and pulling back the sheath and delivery catheter. And again, I do this very slowly.
Can we have injection here?
Can we have a little injection?
You see the ball?
Very good.
Yeah.
Looks good.
Can you store the image? Yeah. So looks like we are a little bit behind the circumflex, which is fine.
Yeah, and sometimes with the tug test, you become
Yeah.
you line it up.
Important point, let's do the tug test always first, because you
Yeah.
have to do a tug test anyway, and as you mentioned, due to the tug test, the position may change. Ready for inject? Ready for tug test? Inject? Okay.
There you go. Now you're better. And all you have to do sometimes is wait a couple of seconds, and then the night lull expands and the feet expand.
Yeah.
Horst, does a little bit of trabeculated appendage that's proximal to the device matter?
What do you think?
It's not LAA, it's left atrium, and we have this discussion every year also.
Well, yeah, but are you sure it's
There's no
left
proof.
atrium?
There's no proof yet there's any advantage of closing that. Where's the head-to-head trial?
So
We'll see it.
Look at the diameter here. So it's 17.7, which means if
Super compressed.
Yeah, it's super compressed.
It's going to come out to the other side of the wall.
Yeah, and in that position, a 21 millimeter device would have been nice.
Yep.
But the question with LAA closure is always to predict really where the device will end up. And if this device would end up a little bit more in the left atrium with a bigger shoulder, then it may be the 21 would not have been enough. But
Well,
that's
I
speculation.
think just a matter of it's a kind of semantics, but a 21 would have fit here because you are super compressed.
Yeah.
The question is, everybody here in Europe believes that there is no penalty on super compression. If that's what it is, if that's real, that's one thing. But I believe that there must be some, and we've had some at the beginning of Middle Protect AF, late effusions, and all of them were with significant compression. But But this has not been born to be true here.
Yeah.
So maybe it is again the American diet that's different.
So
We've
now,
not seen,
Maurice,
we've not
at
seen
this,
it in evolution, but can we see the measurements in echo? Because I think compression will be different in various angles. We've seen the 135, which is
It was 15 was compression at 135. Should I measure at each position?
No, I mean, we want to assess compression in all four angles.
Okay.
And,
Okay.
I mean, before implantation, the 135 here was one of the smallest diameters, wasn't it?
Yeah. Okay.
yes, correct. So Maurice, looking
Okay,
at
at
this so
0
far,
degree?
would you retrieve the device and go for a smaller now, in case you had decided to use a 24 at the beginning? Or would you leave it at this stage?
No, it looks very fine.
Okay.
One at 0 degree was 15.
So what is the measurement now at 135? 0?
0 was 15, now 45, 15, 16.
So the device is measuring 16.
So now I am at 90. 90?
Yeah.
So the same, 16.
Yeah, so it's super compressed.
Well, Nora,
Martin,
shouldn't you measure a little bit more distally?
No, she's measuring right.
Yeah.
I am every
Look
time
at this.
measuring
Look at this.
right.
Look at this. Here.
You are slightly foreshortening that device when you're measuring it, though, because you need to be able to see the center
17.
pin.
17.
Yeah, that's better. Yeah.
That's
Okay,
fitting
so
my
16, 17 with the 24 device. So who's the mathematician here in the
It
audience?
means 33% compression.
33%. And it's kind of getting up there. So in retrospect, a 21 could have been okay.
Agree with that. But you would leave it now, right?
Absolutely.
Okay. So then we are basically, if nobody is against it, we are ready to release. If anybody is against it, you should say it now or be quiet forever.
Yeah, no one has a button on.
Okay. So I will release it here. I'll do this on the center. It moved a little bit, as you see, so it was a little bit under tension. Did you see a change on echo? No, it looks similar, right? Which means we pulled on the appendage here.
If it held back a little bit better because you could see it liner and it tilted correctly.
Yeah. Let's do the final angiogram, and then you can proceed with your leg press, inject.
Good.
Yeah. Okay.
Looks trabecular.
Good.
Good
If
work.
there are no any other comments or questions?
I mean, Horst, the proximal bit to this device looks trabeculated. What's left?
Here, this one.
He's looking on
angio.
The same, you
Angio.
can see the same.
No, but
Kevin is angio driven. And what he means is this
Here, this part.
this area from here to here, right?
yeah, Kevin is looking too closely.
Yeah.
Okay. Maybe it does. It probably. I mean, the trials suggest it doesn't matter.
Exactly.
Yeah.
I think what could be discussed, if you had taken the device a little bit more outside to the left atrium, you could have covered these trabecula. Well known that there is a shoulder in the 135-degree view then. That could have been an option, especially with a large device.
To me, this implant is fantastic. It's great. A little over compressed, but that's all what it is. But it looks very nice.
Okay. Okay, then thank you very much, and you should continue with your lectures. Thank you.